continue with our lecture, we will now be talking about the bleeding disorders. So these are the possible causes of bleeding disorders. It may involve the blood vessels, and if you examine it in the laboratory, almost all of the parameters would appear to be normal. Second would be disorders involving the platelet. It may involve a number of platelets. So laboratory parameter, there would be a decrease in platelet count and probably a prolongation of the bleeding time. Another test that we also do for platelet is platelet function. So the platelet count would be normal, but there would be prolongation in the bleeding time. This is what we call the qualitative platelet defect, as opposed to the quantitative platelet defect, wherein the decrease in the number of platelets is pronounced. The third possible cause of bleeding disorders would be clotting factors. So it may involve the intrinsic and extrinsic pathway of coagulation. So what are the parameters that would be elevated in cases of bleeding disorder secondary to clotting factors? There could be prolongation in the clotting time, an increase in the prothrombin time, and increase in your activated partial thromboplastin time. Let's talk about vessel wall abnormality. So most often they would present as small hemorrhages in the skin or mucous membrane, and they are usually called as non-thrombocytopenic purpura. And as I have mentioned earlier, almost all of the bleeding parameters, the laboratory tests for bleeding disorders are normal. So it may be caused by infectious agents such as your Neisseria meningitidis, viral infections such as your measles, as well as in cases of infective endocarditis. It may also be caused by deficiency in vitamin C, like what we see in scurvy. You may also see this in some of the connective tissue disorders such as your Ehlers-Danlos syndrome, drugs such as penicillin and sulfa antibiotics, henoch-Schönlein purpura, and a hereditary hemorrhagic telangiectasia syndrome, also known as Weber-Osler-Rendu syndrome. So let's talk about the quantitative platelet abnormalities. So a decrease in platelet, there has to be the normal platelet count is between 150 to 450,000. If your platelet go as low as 20,000, you would expect spontaneous bleeding without any provocation. And if the platelet count is between 20 to 50,000, you would expect post-traumatic bleeding. So characteristic of bleeding that we see in platelet disorders, they are mostly small hemorrhages or petechial hemorrhages that are often seen in the skin and the mucous membranes. There would also be a manifestation of easy bruising, like if you bump yourself into the table or any hard surface, you would expect increased bruising. We may also see gastrointestinal and as well as genitourinary bleeding in the form of melena or black tarry stools, hematuria, as well as menorrhagia or increase in menstrual flow. The most feared complication of a very low platelet count is a threat of intracranial bleeding. So what causes thrombocytopenia? It may be secondary to bone marrow disorders such as aplastic anemia and myeloproliferative anemia. It may also be a result of ineffective megakaryopoiesis like what we see in cyanocobalamin deficiency. It may also be a result of destruction of the platelet like what we see in certain infections such as dengue hemorrhagic fever, or could be an immunologic reaction like production of antiplatelet antibodies or drugs that could possibly produce antibodies to destroy the platelet. We may also see this in massive transfusion as well as platelet sequestration, which also happens in certain cases of infectious infectious causes of thrombocytopenia, like what we see in dengue hemorrhagic fever. There is a cause of thrombocytopenia that is secondary to the intake of an anticoagulant drug called heparin. There are two types. You have HIT1 or heparin-induced thrombocytopenia 1, which happens 1 to 2 days after treatment of heparin. This is not clinically significant, and you may continue giving heparin. What is more significant is your heparin-induced thrombocytopenia type 2, which occurs 4 to 14 days after treatment. And this could be life-threatening, so that we have to stop the giving of heparin. This is almost similar to if you have heard the news, one of the complications of some of the COVID vaccines that have been given, the AstraZeneca vaccine as well as your Johnson and Johnson vaccine, they have noticed an almost similarity to this heparin-induced thrombocytopenia. But the thrombocytopenia that we see after vaccination with certain brands like AstraZeneca and J&J has a name. It's called VPIT, or vaccine-induced prothrombotic immune thrombocytopenia. So it's called VPIT, VIPIT, vaccine-induced prothrombotic immune thrombocytopenia. It's almost similar in presentation with heat type 2. Let's talk about abnormalities in platelet numbers. So this is what we call the quantitative platelet defect. First is what we call your idiopathic thrombocytopenic purpura. It's an autoimmune disorder wherein we produce antibody against the platelets. The bone marrow may be normal, or we can see increase in the number of megakaryocytes. Acute ITP could be a self-limiting disorders that are often seen in children, which usually follows a viral infection, a systemic viral infection. Then chronic ITP is seen mostly in adults, usually seen in reproductive females with autoimmune disorders such as SLE, rheumatoid arthritis, or lymphoproliferative diseases like lymphomas and leukemias. Next is your TTP, or thrombotic thrombocytopenic purpura. This is characterized by microangiopathic hemolytic anemia, fever and transient neurologic deficits, renal failure usually noted in females in the 4th decade of life. So morphologically, the blood vessels, especially the smaller blood vessels like the capillaries, the venules, would present with widespread hyaline microthrombi. The pathogenesis of TTP is there is excessive activation of platelet due to deficiency of the enzyme ADAMS13. So what is the role of ADAMS13? ADAMS13 degrades von Willebrand's factor. So in the absence of von Willebrand factor, there would be excessive activation of aggregation and activation of platelets. So how do we treat TTP? Most of the time, we would treat it with plasma exchange. And the differential diagnosis, there is a disease that is almost similar in presentation as with TTP. This is your hemolytic uremic syndrome, but one of the differentiating factors of TTP with H2S is that there is the absence of neurologic deficits. H2S arises from an infection from E. coli. So this is your enzyme ADAMS13. So in cases of TTP, this is deficient. So there would be decrease in degradation of the von Willebrand's factor. And as you know that if there would be increase in von Willebrand's factor, there would be excessive activation, platelet activation, and platelet aggregation. So the activation and aggregation of platelet contributes to the decrease in the platelet count. Next, we have what we call the hemolytic uremic syndrome. It has similar manifestation with TTP without the neurologic manifestation. In this case, since it's called uremia, the renal manifestations are very prominent, and you also have very prominent signs and symptoms of hemolysis. So you also present with widespread hyaline thrombi, and the pathophysiology of the disease is a result of excessive activation of the platelet by a Shiga-like toxin that is produced by E. coli. Let's talk about abnormalities in platelet function. This is what we call the qualitative platelet defect. One would be your von Willebrand's disease. You have a defective adhesion as a result of a deficiency in the von Willebrand's factor. Then Bernard-Soulier is there is a absence of glycoprotein 1b, so adhesion would be a problem in Bernard-Soulier disease. Then we have Glanzmann's thrombasthenia, where you have defective aggregation as a result in the deficiency of glycoprotein 2b and 3a. Then you also have acquired abnormalities in platelet function like intake of aspirin and NSAIDs, we say that these two drugs would inhibit cyclooxygenase and inhibits prostaglandin, in particular prostacyclin, which is a potent platelet aggregator. Uremia can also contribute to qualitative platelet disorder because there could be a uremia suppresses the function of platelet factor 3. So this is your Bernard-Soulier, this is your Glanzmann's thrombocythemia. Then another would be a deficiency in your von Willebrand's factor. Let's talk about this time clotting factor abnormalities. So this time, there would be spontaneous bleeding as well as prolonged bleeding. Most of the time, the sources or the sites of the bleeding are deep-seated sites. You don't see them in the skin as well as in the mucous membranes. You can see bleeding in areas such as the joints. Ang tawag natin dyan, hemarthrosis, or bleeding into the joints, arthrosis. And also in the serous cavities such as the pleura, the pericardium, and the peritoneum. Since this is a clotting factor abnormality, all the platelet parameters are normal. So normal platelet count, normal bleeding time, but there would be a characteristic increase in clotting time. There could be elevated in the elevation or prolongation of the prothrombin time because we know that the pro time is a marker of extrinsic pathway of the extrinsic pathway of coagulation. So this would involve the following factors: factor 1, factor 2, factor 5, 7, and 10. Elevated APTT is a reflection of both the intrinsic as well as the common pathway. So let's talk about the specific clotting factor disorders. If we talk about classic hemophilia, there would be a deficiency in factor 8. Then Christmas disease, there would be a characteristic decrease in factor 9. And liver disease, almost all of the factors would be deficient with the exception of factor 8. So others would be vitamin K deficiency. So this would involve 4 clotting factors, which we all know are vitamin K dependent clotting factors, or in their activation is dependent on the adequacy or presence of vitamin K. So this is factor 2, 7, 9, and 10. So para hindi nyo makalimutan, 19, 7, and 2. So 1972 is a very remarkable year in our history, since this was the year when President Marcos declared martial all over the country. Others would be deficiency in protein C and protein S. Von Willebrand's disease almost behaves like a clotting factor deficiency, but what happens here is the deficiency in the von Willebrand's factor. It behaves like a clotting factor abnormality, but von Willebrand's is really a platelet disorder because von Willebrand's is needed for platelet function, as well as it is also needed by factor 8 for stability. So if you would look at it, the bleeding are mostly in the superficial areas from mucous membrane, bleeding from wounds, menorrhagia, and there could also be deep-seated bleeding. But if you would try to examine patients or the laboratory of patients with von Willebrand's disease, platelet count is normal, but with elevation of bleeding time as well as elevation of APTT, or your activated partial thromboplastin time. There is also a reduction in the ristocitin aggregation test because ristocitin is a reflection of von Willebrand's factor activity. Okay, going back to hemophilia, most patients would present with prolonged bleeding that is noted early on. And most patients with hemophilia A, or the classic hemophilia, are usually males because they say that the females are just carrier of the abnormal gene. It is usually expressed in males, and I think you already know why. In most females, they would not express the disease, especially if they are inherited by sex-linked mechanism. The explanation for that is that the extra X chromosome has a dilutional effect on the abnormal X chromosome. Females may also manifest hemophilia if the female would inherit both abnormal gene from the male and the female parent. But most often this is manifested mostly in males because the males only has one X chromosome, and if the X chromosome carries the abnormal gene, there is no extra X chromosome to have a dilutional or a inhibitory effect on the abnormal of the X chromosome that carries the abnormal gene. Next, we have disseminated intravascular coagulation. This is an acute or could be a subacute or chronic thrombohemorrhagic disorder that occurs as a complication of a lot of diseases. So it may be secondary to obstetric complication, it may be secondary to some cancers, it may be secondary to certain infection, as well as massive tissue injury. So this is a pathophysiology of the ICU. Have excessive endothelial injury, there would be release of clotting factors from the tissue, and there would also be platelet activation. So the result of this would result into a widespread thrombosis, since the presence of the thrombus would entail the consumption of clotting factors and platelet, and the presence of a thrombus to restore the blood vessel to its and one of the ways by which we can achieve homeostasis in the blood vessel is, of course, to activate fibrinolysis. So consumption of the clotting factors as well as fibrinolysis would result into what we call a very lethal or a fatal form of bleeding that accompanies DIC. So again, there would be formation of microthrombi, especially in the smaller blood vessels. Laboratory diagnosis for acute DIC, all of the bleeding parameters would be abnormal. There would be thrombocytopenia, prolonged in bleeding time, prolongation in the clotting time, also prolongation in the PT as well as PTT. With chronic DIC, aside from the prolongation of the bleeding, some of the bleeding parameters may already normalize, but there would be appearance of D-dimer and fibrin split products. So these are all evidences of fibrinolysis. So microscopically, this is what we see. This is in the glomerulus, where you can see some smaller thrombus. This is a capillary with an alveolar capillary, for that matter. You can see some thrombi within the alveolar capillaries. So these are some of the pictures that you can see from patients with DIC. Let's talk about some of the clinical syndromes that could be associated with bleeding. One is Waterhouse-Friderichsen syndrome. This is a result of disseminated meningococcemia producing a very pronounced adrenal hemorrhage. So the hemorrhage here is a result of elaboration of endotoxins from the Neisseria meningitidis. Another is your Sheehan's postpartum necrosis, wherein there is a hemorrhage of the pituitary gland as a result of complicated delivery, or ischemia of the pituitary gland as a result of a complicated or a very difficult delivery. Let's talk about hypercoagulable states. We have inherited causes of hypercoagulable states, such as your deficiency in factor V, either a protein C or a protein S deficiency, and elevated homocysteine. And the acquired hypercoagulable state is what we call your APAS, or your antiphospholipid antibody syndromes. We know that protein C and protein S is part of the anticoagulation system. We know that protein C and protein S would degrade factor V and factor VII, and it also inhibits inflammation. So in the absence of protein C or protein S, you would expect an increased formation of thrombus, or what we call a hypercoagulable state. So let's talk about this time the complications of blood transfusion. It may come in the form of a febrile non-hemolytic reaction, which is a very common reaction. This is not a fatal reaction, but we are alarmed when we see a febrile reaction, because this could be a start of a hemolytic reaction. Next, we have allergic reaction. It may be mild, as in it may just present with rashes, or could be severe. It may present as a anaphylactic type of allergic reaction, or it may be potentially fatal, like in what we see in patients with IgA deficiency. Then we also have what we call hemolytic reactions. You have IgM antibodies reacting against the donor red cells. This is secondary to ABO incompatibility. Okay, so it may also present with a delay. This could either be an acute hemolytic transfusion reaction, or could be a delayed hemolytic transfusion reaction. Hemolytic transfusion reaction would take place in just a few minutes to several hours post-transfusion, whereas delayed hemolytic transfusion reaction, the hemolytic reaction may be manifested a few days or even a few weeks after the initial transfusion. Then also have what we call your transfusion-related acute lung injury. Most of the time, this has been what is implicated are your MHC class 1 lymphocytes. It has an incidence between 5 to 67%. Most patients would present with like an ARDS type of lung injury. And it has to be differentiated from what we call TACO, or transfusion associated circulatory overload, because both would present with pulmonary manifestation as well as ARDS type of lung injury. But with TACO, you can see this in massive transfusion, and could even manifest even in the first initial transfusion. Whereas with TRALI, it takes some time to develop. The injury. It could be a result of repeated, or there could be a history of previous transfusion, which could stimulate the MHC class 1 lymphocytes. So that is the difference between TACO and TRALI. So TRALI means transfusion-related acute lung injury. This could be both TACO and TRALI would present with pulmonary manifestation, an ARDS type of lung injury. The difference is in TRALI, it is secondary to lymphocytes attacking the lungs, whereas TACO is some sort of like a congestive heart or acute congestion in the lungs as a result of massive transfusion. Then we also have what we call our TTIs, or the transfusion transmitted infection. These are infections that we could get from transfusion. That is why we are very careful in screening this possible infection that can be transmitted by transfusion. So this would involve HIV, hepatitis B and C, as well as malaria. So this is the source of my lecture. I took it from the 9th edition of Robbins, not yet the 10th edition. Okay, so I would like to end my lecture here. Thank you.